I invite the next speakers, Dr. Nalini, Kopalle and Purnima Agrawal for a case. TSH is 3.9 milli international units in 7 weeks primary gravida. A situation which is so much common in our practice. Almost 7 to 10% of the patients have hypothyroidism in pregnancy, so kindly dwell upon that.
True. At the outset, let me thank the organizers for giving me this opportunity to talk on a topic so important and so we come across very, very frequently. And what do? That's where we are. So today to discuss this with me is Dr. Purnima Agrawal. She is Associate Professor of Endocrinology from Safdarjung Hospital. And what happens to thyroid function? Do you think it is the same or does it change during pregnancy? Yes? Changes. But how does it change? Does it change uniformly? Does it have a pattern? This unravels the mystery and situations which compel us. When we look at TSH 3.9, 7 weeks pregnancy, only answer that majorly pops up it, kuch ho na jaye, let us treat. But do we have to treat? Is it imperative to treat? We need to understand that. So in 5 case scenarios, starting with the physiology of thyroid functioning a little, we'll deal with this enigma wherein do we treat, don't we treat, do we consider treating, what do we do? So Purnima, what happens to thyroid function during pregnancy and what is the role of subclinical hypothyroidism? Does it have an impact?
Yeah, this is a good question. Actually, pregnancy has a profound impact, that all we know. But the more important thing is that little basics are important before we go for such a debate like what is subclinical hypothyroid, what is overt hypothyroid. So if you see this graph, this you all must be knowing, but I just want to highlight that during pregnancy, the increase in the demand for the thyroid hormone production, almost the 50% increase in the demand occurs because of the increase in the thyroid binding globulin and T4 production. And because of increase in the human chorionic gonadotropins, which is a weak agonist of the TSH, it stimulates the production of the T4. So here you can see that at about 10 weeks to 12 weeks, HCG is elevated, and at the same time, because of the increase of T4, the TSH gets suppressed. So normally also in a pregnant woman, the TSH in the first trimester is little bit on the lower range as compared to the non-pregnant state. And this TSH gradually picks up in second and third trimester, but still it is lower as compared to non-pregnant state. And that is how that question arises, that what cutoff the TSH we should keep in the pregnancy state because of these physiological changes that occur in pregnancy. So this this is just this thing. Coming to the impact, that why we are so much worried about this subclinical hypothyroid, what are the impacts on the fetal and maternal outcomes. So overt hypothyroidism, we have clear-cut evidence that yes, it has a poor maternal and fetal outcome. And why it is so? One is fetus, the thyroid gland develops by the 11th week, but it matures by 18 to 20 weeks. So till that time, the fetus is completely dependent upon the maternal thyroid hormones available. So at that time, if the thyroid hormones are not there, then fetal, especially the neuronal migration, myelination, and structure of the brain development is affected. So that is why we are very much worried about the fetus. And coming to the pregnancy outcome, we have a very good meta-analysis which was done by the Maraka et al. On 4,000 women with subclinical hypothyroidism. They clearly demonstrate that there is an increase of the pregnancy loss, increase in the placental abruption, premature rupture of membrane, and neonatal death. So definitely subclinical hypothyroidism has an effect on maternal and fetal outcome. But the problem is, again, what cutoffs that we should use. So Dr. Nalini, please tell us that what is the debate and what cutoffs that we should use for the TSH to define subclinical hypothyroidism.
Very pertinent point, Purnima, because we know that hypothyroidism has an impact. Subclinical also has an impact now. So what is the cutoff? What do we know about it? we go back a little in the history about a decade wherein ATA in 2011 has given certain cutoffs. It said that first trimester upper limit for TSH is 2.5 milli-international units per liter, and second and third trimesters it is 3. But it was found after in certain subsequent studies that ethnicity, iodine status and anti-TPO antibody status, they play an important role. And because of these things, ATA 2011 guidelines were revised in 2017. And we'll see those guidelines in a short while, but what do our guidelines say? What do the European guidelines say? ITS, Indian Thyroid Society, as well as European Association in 2012 and 2014 respectively have said that they are sticking with ATA 2011, and they said that 2.5, 3 and 3 still holds good. But then Indian Thyroid Society with WOXD and ATA 2017, they have in the latest guidelines of ITS in 2018, I believe, and ATA 2017 guidelines. They say that local reference value is important because you're talking about ethnicity. We are talking about the genes impacting the levels. So local values, wherever they are present, that is very important. But if the local value is not available because of the paucity of data, probably the country has not done. Or in a country like India, where the East India person is different from the person who's in the north, is different from west. We are totally genetically diverse, and we don't know how to take the ethnicity of our population, Indian population. In such situations, a cutoff of 4 milli international units per liter is considered prudent for subclinical hypothyroidism. And anyone who is under 2.5 is considered okay anyhow. So now we have this pregnant woman who is in that gray zone of 3.9 and with early pregnancy. So we'll discuss in 5 case scenarios shortly what to do. Will there be a question? Because this is a gray zone, obviously. We don't know whether we have to treat here because it's more than 2.5, but still it is less than 4. So in the first case scenario, Dr. Purnima, please.
So we have the first case scenario. She is a 7 weeks pregnant woman and the TSH is 3.9. When we look at the history, she was spontaneously conceived. There was no history of thyroid disease, no family history of thyroid disease or any other autoimmune disease. On examination, no goiter. Skin, there were no autoimmune markers. We also asked for the anti-TPO antibody, which was negative. So what should we do? What is your answer in such cases?
What do we do? Treat or not treat? Don't treat?
So I think audience are right. So we will not treat this case. Why? Because we don't have any risk factors in this patient and her TSH is less than 4. As per current guidelines, it is less than 4. Yes, it is in the gray zone of 2.5 to 4, but we don't have any other risk factors. So what does ATA 2017 recommend? That levothyroxine therapy is not indicated in anti-TPO negative women with normal TSH more than 2.5 and less than 4. So coming to the anti-TPO antibody, why I have advised? Anyone?
Any reason anti-TPO antibody was ordered by Dr. Purnima in this particular patient? No, what is the importance of anti-TPO? Is it important?
Because the hormones will fluctuate. They might be normal at present, but if TPO antibodies are positive, she is more likely to have fluctuations.
Absolutely,
Especially in first
absolutely.
trimester.
So anti-TPO antibodies, it has been seen in the studies that those women who have anti-TPO positivity, their TSH is slightly on the higher side as compared to the women who are anti-TPO negative. And these women will have the progress increase in the TSH as the pregnancy progress, even though anti-TPO antibody titers decreases. The reason for this is not known. And the second most important thing, it has been found that this TPO antibodies impairs the activity of HCG. That is, impairs the free T4 production. So why exactly that area is not known, but it has been clearly seen in the studies that it impairs the production. And as I have told you in the very beginning that the demand has increased, 50% increase has to occur in the pregnancy. It is a stressing state. So at that time, if the amount of the thyroid hormone production is impaired, the chances of developing subclinical hypothyroidism is increased. So anti-TPO status is very important in any women who have a gray zone or subclinical hypothyroid or overt hypothyroidism. So coming to the second scenario, the same patient, but now the anti-TPO is positive, strongly positive. So what will you do, whether you treat it or not?
Treat.
Yes.
Treat.
So in this women, treatment may be considered, yes, because it is a gray zone. Anti-TPO agar slightly positive hota, we may think that there are no risk factors. Risk factors like twin pregnancy is one of the risk factor. Whether she has taken any assisted reproduction is a kind of risk factor. But if nothing is there, we may wait. But otherwise, treatment is considered. It is better or safe to treat. So ATA 2017 recommends that levothyroxine therapy may be considered in anti-TPO positive women whose TSH is more than 2.5 but less than 4.
What about euthyroid individuals? Euthyroid, but completely. TSH is less than 2.5. Somebody has ordered for anti-TPO and it has come positive. What do we do for those women?
Yeah, so since anti-TPO is a risk factor and these women have a very high chance that may go for subclinical hypothyroid, so I would like, or it is recommended also, to monitor these patients for TSH every 4 weeks throughout the gestation. And ATA also recommends that euthyroid pregnant women who are TPO positive should have the measurement of serum TSH concentration performed at the time of pregnancy and then every 4 weeks till throughout the pregnancy. So coming to the third scenario with a different situation, Dr. Nalini, kindly.
Right. Till now we were dealing with probably a normal thyroid or probably a diseased thyroid. But then now we deal with a 7 weeks pregnant woman with TSH 3.9. The case scenario seems same, but then she's a primate, spontaneously conceived. She is a known case of thyroid disease. She is hypothyroid on treatment with levothyroxine, and when measured at 7 weeks, it's 3.9. What do we do? Correct it, because the most common cause of subclinical hypothyroidism is undercorrection with levothyroxine replacement. So we need to understand, as already discussed by Dr. Purnima, the requirement of thyroid hormone increases during pregnancy because of the various reasons. And the increment in early pregnancy is also to the tune of 20 to 30%. It's imperative that we correct it. And how do we do this? The easiest method is, if a known hypothyroid individual is planning for pregnancy, we tell the person, you have to increase your dose by 20 to 30%. No, the patient will not understand this. You need to tell the patient to take at least 2 extra doses per week. Easiest thing is, if the patient is taking dose X, take that same dose X Monday to Friday, Saturday and Sunday, double it. Easiest way where they will remember it. And even the recommendation says that we need to increase the dose at least twice and then report it to the endocrinologist that you have conceived and this was my situation, I was taking a dose.
We are rather doing it at preconception counseling only. We'll like to keep it below 2.5 if the patient is planning for conception, if she's already on treatment.
Yes, and even when we are keeping it below 2.5, because of the increase in estrogen and subsequent TBG increases, the rise will be up to 20%. So when we are doing weekly, as we know, levothyroxine half-life is 7 days, we can do these weekly adjustments, and that is very much within the control of the woman. The woman feels empowered, she knows she is in control of the situation, and that gives a lot of confidence in women, especially in Indian scenario where they do not know what to do or medical assistance is not available. So moving on to another kind of disease, thyroid. This is a woman who has had hemithyroidectomy done for solitary thyroid nodule. She was euthyroid. She is not using anything, perfect. TSH was 2.5 before conception. Now she has conceived. What do we do? What do we do? Treat or not treat or consider?
Treatment has to be continued.
We should treat this person and increase the dose because requirement increases. A disease or resected thyroid cannot perform or cater to the increased needs of the pregnancy. So it's imperative that we treat this patient so that the increased demands are met with. The guideline in 88/2017 also says that in such situations wherein there is anti-TPO antibody positivity post-hemithyroidectomy and who have been treated with radioactive iodine and at the time of conception they are euthyroid, even then you have to treat because this is a diseased thyroid which is not able to perform when more is needed from it. So moving to the last scenario, okay, all this while spontaneous conceptions, nothing. Now this is a precious pregnancy, assisted pregnancy. Dr. Purnima.
Assisted pregnancy, now it is very common. Slightly we have a different physiology in assisted pregnancy. So in this case, same women with no risk factors, even anti-TPO is negative, but the pregnancy is assisted. Then what we should do in this scenario? What you people usually do?
Treat.
Outright treat, consider, what do we do?
Yes.
Treat. So,
We'll come back to that shortly.
Yeah, I think that is more appropriate. In this case, you may consider the treatment because she has already conceived and now she is coming to you at 7 weeks of pregnancy. And many observational studies have shown that you are not increasing the pregnancy outcome or live births by controlling the this TSH levels. But yes, if she has come before and you are planning for ovulation or hyperstimulation, in that scenario it is very important to keep it less than 2.5 because you are going to give a lot of estrogen to that patient, and same thing will happen that the TBG will rise and the demand of the thyroid hormone will increase. So at that time the TSH has to be kept less than 2.5. So what does this recommendation of 2017 guidelines say? Any infertile women, yes, we should do TSH. If she is already overt hypothyroid, then we have to adjust the dose and keep our TSH levels less than 2.5. And if the patient is going for the treatment, then also we should better to keep it less than 2.5. And already I have discussed that if she is going for the ovarian hyperstimulation, then that is a very important point. So
the take-home message. Man has to be considered in his environment as an entity, and so definitely does a woman, and she should be. So it's not just important when we say early pregnancy and TSH level. There are so many important things wherein we need to consider before proceeding. There are points in history that are important. Probably she underwent hemithyroidectomy. Probably she has had a thyroid disease. These are all so important to understand. And so is examination very important. Maybe she doesn't have anything. Probably she has vitiligo. And then when we are testing, anti-TPO antibody testing should be done, especially when we are in the gray zone. So these things tell us that's important not just to jump in and treat when we see a TSH of 3.9 and early pregnancy 7 weeks. No, we need to consider it objectively, define the circumstances, and then go about it. Thank you so much.
And one important message is screening for other autoimmune diseases like diabetes.
Thank you, Dr. Nalini and Dr. Purnima, for especially highlighting the role of anti-TPO antibodies and making us very clear that when we should treat and when not, and make the patient also understand that we really need to tighten the dosage all through the pregnancy and afterwards also.
And repeat TSH at least one value in each trimester for obstetricians.
Observation status, yes, but then during treatment, when the person is already on levothyroxine treatment or in certain conditions that we discussed, it should be done every 4 weeks.
Yeah.
When we explain this to the woman, she understands it. Otherwise, the expression is like, do I have to get it done every month? If we tell them that it is needed because the dose can change, because of the variability in the thyroid disease also that can happen, and the changes in the TSH that can happen, and then anti-TPO status and effect, or there's a new onset thyroid disease that is happening. All these things cannot be predicted during pregnancy. So it's important to explain it to the woman that once in 4 weeks testing is essential. In Western population, only till mid-pregnancy, that is up to 30 weeks is considered, but then we need to do it till 34 to 36 weeks at least, because the deiodinase which is expressed from placenta, it inactivates, and this is much more so in Southeast Asians. That is the reason why we need to monitor these women for till 34 to 36, till term, I would say.
And again, the importance of postnatal counseling, contraception, and neonatal screening.
Yes, that's very important.
Right.
Thank you so much.
Thank you. Thank you.
Thank you so much.